Well, thanks, Amresh, for that introduction, and good evening, everyone, and thanks everyone for joining uh, in a busy day after working so long. Well, so in coming 20-30 minutes, we will speak on what is the impact of nutrition in cancer patients. We have been we have been speaking of cancer care in the form of surgery, radiotherapy, chemotherapy, and we also address the supportive care part with mucositis. Then we also address febrile neutropenia, and diarrhea, infections. All these we address. So we hardly speak about nutrition in an oncology platform, and the initiative is always with the patient. Whenever the patient leaves our OPD, whatever sick the patient is, whether the patient is an early stage disease or whether the patient is an advanced stage disease or whether the patient is terminally ill, the only question the relative asks is, what can I give for my patient to eat? What is the diet that is best designed for my patient? So very unfortunately, all of our doctors we are a little uncomfortable to answer. We say whatever she wishes or whatever the patient wishes, you give. There is no problem. This is the usual answer we give to our patients and their relatives, and they're not that convinced. They just go one step ahead and ask, "Sir, tell me, we can give kaju kishmish. Can I give apple?" Then they start questioning each food. They can give fish. They can I eat one piece of meat? And they say milk. And what about sugar? If I eat sugar, my cancer will increase. So nutrition is a very important part, of course, in terms of what is perceived from the patient and the relative, and it is extremely important as far as the cancer management and the cancer outcomes, recovery and rehabilitation. Every part, nutrition plays an extremely important role, and you will see in the following slides. So when we ourselves become feverish or sick, we always get this in mind. Will this? Can I be able to eat this? So in a sick patient, nutrition becomes as important as treatment. So it's not just enough if I give a surgery, radiation, or chemotherapy or supportive medications for diarrhea, vomiting. It's extremely important to stress on the nutrition part, because that is what the patient can do from himself, and the patient enjoys doing it. So we must equally focus on this component of nutrition, and we should not ignore, and we should not say that go to the dietitian and speak or whatever it is there, and you get a chart, and then it is difficult for them to follow. They keep asking, sir, is this enough? Can I have 2 cups instead of 1 cup, and all this. So as a clinician, we all must know how to address this question. What can I feed my patient, or what can I eat as a patient? We need to have a comprehensive answer. To have a comprehensive answer, I need to know what is the caloric requirement of a cancer patient, what is the protein requirement, what is the lipid requirement, and I also must know what about these micronutrients, vitamins and minerals and all that. And also I need to assess whether the patient, when takes these protein rich supplements, all of so many patients keep saying, sir, can I eat that powder, can I eat Amway powder, can I eat protein X? So many brands being in market, so it is very difficult to say the patient which is the best thing for you. So for that we need to have a proper idea as to what is the composition of each powder. And if I give, supposing I give an Amway powder that is basically for general population, can my cancer patient digest that? What about the absorption capacity for this? So majority of times they have loss of taste, their taste perception is altered, their absorption is altered, they're in a complete catabolic state. So at the moment we say cancer, the thing that comes in front of our eyes is a cachectic patient with weight loss, not able to eat, vomiting. So this is the patient that comes into picture. So nutrition is an important component of cancer treatment, as important or even more important than oncological management. Unless the patient eats, unless the body's catabolism is tackled with proper nutrition, assessing the patient's demands, patient's perception, patient's priorities regarding food. We need to uh, uh, we have to have proper strategies to improve the nutrition status of the patient, also to assess the absorptive capacity of the patient. Okay, so with this in background, let us go through the following presentations, which have some basic concepts of how important is nutrition oncology. Okay, you can keep moving the slides. So we know cancer is a disease, especially if you have advanced metastatic cancer. Uh, in early stages, we do agree it can be little handled with motivation, but what about in advanced metastatic disease? So majority of them in a medical oncology OPD present with an advanced metastatic disease. Advanced metastatic disease is a disease where we speak of survival in months to years, and giving proper diet, it becomes extremely important. They will have a rapid fall in weight. If every visit you keep seeing 1 kg, 2 kgs, 3 kgs in a matter of week, so weight loss just happens in front of your eyes. You see your patient just shrinking away with cancer treatment. Scans are better. Uh, uh, we are giving expensive medicines, but the patient is shrinking away. So it's very important to tackle this cachexia part of it, or weight loss part of it. For that, we need to understand this. So you can see malnutrition and loss of muscle mass are frequent in cancer patients and have a negative effect on clinical outcome, driven by inadequate food intake, decreased physical activity, and catabolic metabolic derangements. So a cancer patient has no appetite. I don't have taste to eat. I don't wish to eat. And the patient doesn't walk around. And the body is just getting degenerated. Muscle mass is gone, the temporal hollowness is seen, and you can see shrinking of, you can see wrinkles on the skin, pedal edema just happening in front of you. So therefore, standard operating procedures, responsibilities, and quality control process should be established at each institution involving treating cancer patients. So therefore, it is as important to have, we have a multidisciplinary team to decide whether I'll do surgery, whether I'll do radiation, chemo, or immunotherapy, what I want to do. In a similar way, we must also have a team, a nutritional team, having a nutritionist, dietitian, a counselor, uh, and the treating doctor to be in place, so that they can ensure. We have to first assess what is the nutrition status of a patient when the patient comes to me. We need to have a height, weight, we have to calculate the BMI, we have to see what is the lean body mass, and we have to calculate what is the caloric requirement of the patient. We have to assess whether is there a difficulty in deglutition or absorption. So this assessment, nutrition assessment, is an extremely important thing before we go ahead and give cancer treatment. Just giving whatever protein powder the patient asks is not the way to go. We must have a proper nutritional assessment before we embark onto anti-cancer therapy. That is what I would like to say. Next slide. Yeah, yes. So we know the burden of cancer in India. So in contrast to other countries where we have breast cancer most common, lung cancer, here head and neck cancer is a big problem in India. Because Indians are more addicted to tobacco, and we are addicted to smokeless tobacco. We don't have, we have the poverty to buy cigarettes, we cannot buy, so we use smokeless tobacco with tambaku, pan, gutka. And the patient will develop something like oral submucous fibrosis where he cannot even open his mouth. So nutrition becomes an extremely important thing in head and neck cancer management. So squamous cell carcinoma of oral cavity, of upper end of esophagus, or whatever esophageal malignancies, they are extremely common in India, and you don't see this much volume in any other part of the world. Also in eastern part of India, where there is a surge of non-vegetarian food with red meat, we see GI cancers in a very high variety. Pancreatic cancers, stomach cancers, colon cancers, gallbladder cancers are seen right and left. All these patients have nutritional challenges. So India, yes, constitutes a large chunk of patients with cancer, but Indian patients in Indian scenario, head and neck cancers predominate, GI cancers predominate, and especially in eastern part of India, you can see the predominance of GI cancers because of the dietary habits. Next slide. These numbers we cannot remember. So this is the image of a cancer patient. When I say cancer patient, this is what the image comes in front of my eyes. Patient with bones, rib cage visible, with uh, uh, with the tummy just stuck to the belly, stuck to back. So this is a cachectic cancer patient, and over and above, in advanced cancer patient ultimately reaches this particular point at the end of life. So in 80% of patients, uh, uh, nutrition is undertreated. There are nearly 30 to 40, 85% of patients will have malnutrition. It is very difficult to find a cancer patient without weight loss. So, over and above, as the cancer cells keep increasing in log numbers, the body keeps on shrinking, and finally they attain what is known as cachexia, and then they go into what is known as refractory cachexia and death, which I show in the further slide. So, it's a vicious circle. Cancer increases, patient doesn't eat, immunity reduces, further cancer increases. Again, this vicious circle continues unless we have a proper nutrition assessment and intervening at proper time. This we cannot break this vicious circle. So it is very important to assess and address and prevent these patients from going to cachexia. Next slide. So this is the amount of malnutrition you see. You can see in patients who are orthopedic or neurosurgical patients and neurological patients. Other specialties you see malnutrition less than 20%, but the moment you come to oncology, 70% or even up to 85% malnutrition is seen, because it affects those organs that are required for ingestion, digestion, assimilation, and so on. And oncology is such a catabolic process that the moment it starts, it just goes on and on. So 70% highest percentage or highest prevalence of malnutrition is in oncology patients, and hence the topic is extremely relevant to address nutrition in cancer. Next slide. So, what is the metabolic change? Why should our cancer patients lose life, and why should the cancer patients should lose weight? So, the moment you have cancer, cancer is an inflammatory state. The moment if we have fever, we have this feeling of unwellness, not willing to work, just to rest always. This is the feeling our advanced cancer patients have. The way we find ourselves in a viral fever or viral prodrome, the feeling what we have in those states, that is the same feeling our cancer patients have in those states. This is because of these cytokines. You can see TNF, interleukin 1, interleukin 6, IFN, and STAT3. These are the cytokines that are just poured into circulation. And that is the reason why our cancer patients always say, I am not well, I am fatigued, I don't want to eat food. They're always demotivated because there is a lot of cytokines circulating in the blood. Cancer cells are not normal cells. They keep circulating these cytokines, and cancer is an inflammatory thing, and it is an immunosuppressive disease. So that is the reason why you see what is known as there is increased lipolysis. So what happens initially is glycogenolysis, and then we have gluconeogenesis, and then we have loss of lean body mass, muscle degradation. The protein in which is present in the muscles becomes the substrate for generating nutrients, because the patient is not able to take or not able to absorb the food. So at the muscle level, what we see is increased insulin resistance. Insulin fails to act. That means the glucose that is there in the blood cannot go into the cell because there is insulin resistance. Secondly, there is reduced synthesis in this, and there is increased breakdown. That is what we call as the catabolic state, and there is severe wasting of muscle and fat. And what about in liver? So there is decreased nitrogen loss, and there is increased lipolysis. So over and above, the patient starts losing all the nutrition that the patient had accumulated over a period of time. You can see a 70-60 kg women losing around 30 kgs in a matter of 6 months. That's just magical. And this is because of the lot of cytokines being poured by these cancer cells into the circulation. And very importantly, when there is, these cytokines also have a suppressive effect on the brain. What is known as this appetite center in the brain is suppressed, and they don't have the wish to eat. So this is what is known as role of cancer induced or tumor induced inflammation, which is present, and this causes derangement in metabolism at every level. And you can see the names of the cytokines: TNF, IL-1, IL-6, IFN, and STAT3. So these are the cytokines. This is just like the way when we get fever and when we're unwell at that time, we don't have the wish to eat. It is a similar feel these cancer patients have. Okay, next slide. So this is a good pictorial representation of what I showed in the previous slide. You can see cancer causes anorexia. Not only cancer, the treatment for cancer. For example, I treat an oral cavity cancer. For example, a tongue cancer, I operate the tongue. So the main chewing apparatus, the tasting apparatus is gone for the patient. And the patient becomes dependent on nasogastric tube. That's such a sad scenario. So no taste. Can you imagine a patient having food without any taste? And secondly, you can see the appetite center is suppressed because of the cytokines. There is reduced food intake, and there is malabsorption. So if there is stomach cancer or GI cancer or you have ovarian cancer, there is peritoneal disease. When peritoneal disease is there, there is less blood circulation to the intestine. There is malabsorption. So we always say our patients, you cannot digest food if you take 3 times a day because your absorption capacity is not that great. So we always recommend them for small frequent feeds. The way we have 3 times a day and we are happy with it, that they cannot manage because their absorption capacity is not there. Plus their appetite is not great to ingest that much of food. So our universal recommendation to all our cancer patients, especially advanced cancer, or those to have small frequent feeds so that they can assimilate and they can ingest well. So what are the pro-cachectic factors? You can see anabolism is where the body is forming obesity, what we say, or in a young child just grows on and becomes big, that we call as anabolism. So catabolism is where the body is just breaking away. Body is trying to break every part of the cell. Muscle it is breaking, fat it is breaking for nutrition for the rest of the vital cells like brain and heart and so on. So therefore, if you don't give proper nutrition supplementation for these patients, they start breaking each and every vital cell of the body, including muscle, including fat. So they become depleted of muscle. The lean body mass just shrinks and the fat just shrinks. Therefore, it is very important to have nutrition supplementation before they actually use their lean body mass. So you can see the cytokines having effect on each and every body. So it causes a lot of lipolysis, and it reduces lipogenesis. It causes adipose tissue browning, and then proteolysis is increased, lipid synthesis is reduced, a lot of anorexia being there. Okay. This all results in a vicious circle of cancer-induced cachexia. Next slide. So this is an excellent depiction of how an advanced cancer patient starts his journey and goes on till death. First, he will start with the pre-cachectic stage. It is very important we recognize patients in the pre-cachexia stage. Weight loss of less than 5%. We must be alarmed. Anorexia and metabolic changes. Many a times we see hypertriglyceridemia, high ferritin levels, high CRP levels, even though they don't have fever. This is because cancer is an inflammatory environment. Many of my patients keep doing along with CBC, they do ESR, and they say, doctor, why my ESR is high? ESR is high in infections. So cancer is an inflammatory condition, and that is why ESR is high, and that is the reason why you see a lot of lysis. So very important is we should be alarmed and we should start nutritional assessment and rehabilitation before the patient loses less than 5% of body weight. The moment the patient loses more than 5%, then it is very difficult to bring them back to the state of less than 5%. The body just enters into a ruthless catabolic mechanism. So picking this weight loss early before they enter into the cachectic phase becomes extremely important. Early recognition of symptoms and early nutritional supplementation becomes very important. So we should tackle why there is weight loss. First, I must assess what is the disease status. And then secondly, is there a problem in appetite to the patient? Or is there a problem in the swallowing or chewing apparatus? Or is there dysphagia? Or there is an absorption issue? So we need to assess why there is weight loss. Is it because of less appetite, or is it because of swallowing or chewing issue like that in head and cancer, or is it due to absorption like in ovarian cancer or a GI cancer? So we need to assess every patient as to what is the reason for this weight loss. So we have to nutritionally assess, and we need to categorize them whether it is a pre-cachexia, cachexia, or refractory cachexia. So we need to pick them up in the pre-cachectic state or even before that, and we need to understand the reason for cachexia. And then the second phase is cachexia, where it is difficult to treat. Weight loss more than 5%, BMI less than 20, and weight loss more than 2% or sarcopenia, shrinking of muscle mass, is very important. That means the body is trying to break the muscle protein for nutrition. This is a very alarming thing. So even if there is weight loss of 2% with sarcopenia, muscle mass getting shrinked, that means it's alarming. The patient is entering into cachectic phase and you need to intervene very urgently. So this can be either because of the cancer-induced inflammation in the body or reduced food intake. So we need to assess that. So very important, not just the absolute decrease in body weight. I will wait until the 5% loss. That is not the way. I need to look, is the muscle mass shrinking, what we call as the lean body mass. If there is shrinking of muscles, be alarmed. The patient is getting into a phase of cachexia, which is difficult to treat. And then all patients before dying, they enter into a phase of refractory cachexia. A lot of patients of terminally ill cancers just go on bed finally. They cannot eat, they become drowsy, and they come on the rides tube. And we keep feeding them with enteral and parenteral nutrition. We don't see anything. So they go into a point of no return. Cancer is such an inflammatory disease where the albumin goes down, the edema sets into multiple spaces, pleural effusion, pedal edema, bed sore being there, and ascites. So the fluid starts collecting in all third phases in this refractory cachexia period, and it is very difficult for the patient to get back from this refractory cachexia, and there is hardly less than 3 months left for such patients for survival. So, and these patients usually have a very poor performance status, and ultimately they succumb within 3 months or so. So majority of our advanced cancer patients finally reach this particular stage. So before they enter into this phases of cachexia and refractory cachexia, we must do a proper nutritional assessment, assess why there is weight loss, assess for lean body mass loss, assess is there a sarcopenia which is alarming, and have a proper nutritional intervention accordingly. Okay, next slide. So cachexia has detrimental consequences. 1 in 5 patients with cancer dies from cachexia, not from cancer. This is extremely important. So we see a lot of patients in our clinics where we can give good treatment. We have good chemotherapy, we have immunotherapy, we have target therapy drugs, but the patient says, I feel weak when I take this treatment. Or with one chemotherapy, the patient reaches an ICU. This is because the patients have poor tolerance to treatment. This is not, treating cancer is not treating infection. These drugs are associated with significant side effects. It also harms normal body cells. Therefore, to tolerate cancer treatment, the patient should have an adequate performance status. So we say performance status 0 is when he can do his work just like a pre-disease state. Performance status is 1 is where he can just go to a market and get some vegetables or something near shopping. And performance status 2 is where he can do only his day-to-day activity, like he can go to bathroom and come back and sleep. And performance status 3 is he needs support even to go to toilet. And performance status 4 is bedridden. And PS5 is death. So Performance status and cachexia have an excellent correlation, and the most important prognostic factor for a cancer outcome in a cancer patient is performance status. Is the patient fit enough to receive the best, so-called best cancer treatment? If the patient is not fit, then whatever treatment is there in the world cannot help the patient. So the tolerance to anti-cancer therapy becomes extremely important. And to tolerate, the patient should have a proper performance status. And to have a proper performance status, the patient should have a proper nutrition. If a patient is chaotic, the patient will not be in a state to take anti-cancer therapy. And also compliance to treatment. If I give chemotherapy to a stomach cancer patient, one patient who is well nourished, that patient will come back in regular time after 3 weeks for second cycle. A patient who is not well nourished cannot recover at all. The patient takes more than 2 months to recover from one chemotherapy. And in that meantime, the cancer cells multiply. So to tolerate a proper intensity and doses of chemotherapy, to have the best outcome, you need nutrition to be an important and intrinsic component of cancer care, which I will show in the next slide. Next slide. So this is very important. So cancer treatment, malnutrition. So unless I optimize my nutrition, cancer treatment is not going to be productive. Supportive care part has to be aggressive to have the best cancer outcomes. Okay, next slide. So you can see cancer care is not just treating the tumor. We should treat the patient as a whole, and supportive care in the sense of pain management, psychosocial management, mucositis, anemia, neutropenia, we all agree. But very importantly, I have to have a nutritional support, and we must also stress on physical activity and exercise, because physical activity and exercise increases appetite, increases immune system, will improve the assimilation of food, the absorption of food becomes better. So this is very important, not just nutrition support. We must encourage our patients to have adequate exercise and physical activity so that they can assimilate the food what we have given. So cancer care is not just anti-cancer therapy. Supportive care with adequate nutritional support is extremely important. Next slide. Next slide. Yes. So oral dietary therapy. Oral nutrition supplements, when spontaneous, oral protein calorie intake is insufficient, because either because of difficulty, whether it is because of less appetite, cannot chew or cannot swallow, whatever the reason. In those situations, we must have oral nutritional supplements. So what are the goals of oral dietary therapy? Maximize absorptive capacity of a digestive tract that has limited reserve. So we have so many patients where they have a colon tumor, they have underwent total colectomy, or we have pancreatic tumor where the patient has underwent Whipple surgery, which is the biggest surgery. So in these situations, we have to make sure we give nutrients which are easily absorbed in spite of not going through the intestine. Even though the transit is short, we must be able to give nutrients that get easily absorbed. And we must minimize GI symptoms which reduce oral intake. So very important. So the golden rule of thumb in oncology is always try for oral nutrition. Parenteral nutrition is only as a rescue for a transient period of time because it has a lot of side effects. So whenever possible, shift to oral nutrition. Okay, next slide. So enteral nutrition is infusion of feeding solutions through tubes into the digestive tract. Bypasses obstructions. For example, the patient had esophageal cancer or upper end of stomach cancer, the gastroesophageal junction cancer, or a pylorus cancer with GO. I have a feeding jejunostomy, or I have a nasogastric or a nasojejunal tube. So with this feeding of infusion of feeding solutions through these tubes improves nutritional support. It provides slow continuous infusion of nutrients to maximize absorptive capacity. So it is continuous and slow, so that the intestinal transit is slow and it can be safely used, and it provides access for nutrients which are not palatable. Very important. There are certain nutrients which are difficult to be tasted, and this is the advantage. This is the advantages of enteral nutrition, where you can have an infusion of a gradual long time infusion of this feed, which overcomes multiple disadvantages like obstruction, poor absorptive capacity, and non-palatable nutrients. Okay, next slide. So what is the calorie intake recommended? Calorie and protein intake recommended for our cancer patients. So it is 25 to 35 kilocalorie per kg per day. So if I have a 60 kg patient, around 1800 to 2000 kilocalories is what the patient needs per day. We must be very careful on these numbers. What is the glucose required? Less than 5 grams per kg per day. Less than 5 gram per kg. If I give only glucose rich diet, that is not the way to go. I must give it less than 5 gram per kg per day. If I have a 60 kg, it's around 300 grams per day. And then lipids, long chain, medium chain, triglycerides. So it is 0.5 to 1 gram per kg per day. 24-hour continuous perfusion is better tolerated. Protein requirements is 0.25 to 0.35 grams per day, or 1.5 to 2 gram proteins per kg per day. So you can consider around 1.5 to 2 grams of protein per kg per day. Around 50 to 60 grams of protein will be required for all our cancer patients in adult. Okay, next slide. What are the goals of oncology-specific nutrition? Maintain the body weight or try to increase the body weight, preserve or improve muscle mass and function. This is very important. There are so many diseases where mere improving muscle mass improves cancer outcomes. Reduce inflammation, improve immunity, improve tolerance to multi-modality cancer therapy, which I said before. Okay, next slide. So high protein, high energy, especially lipid, not the carbohydrate part. Consider omega-3 fatty acids with glutamine. This is the recommendation from SPEN. Okay, next slide. You can go to the next slide. Yes. So this is a nutrition modulation of GI. Let's go to the previous slide. Yes. So this is a good paper which addressed glutamine and omega-3 fatty acids. You can see the title of the paper is Nutrition Modulation of GI Toxicity Related to Cancer Chemotherapy from Preclinical Findings to Clinical Strategy. So pharmacologically acting nutrients are a potentially important approach to modulate the therapeutic index of anti-neoplastic therapy. Glutamine and omega-3 fatty acids hold promise to prevent or treat GI toxicities related to cancer therapy. So we give these glutamine and omega-3 fatty acids that definitely reduces mucositis, diarrhea, and also improves absorption. So there is some evidence to say that glutamine and omega-3 fatty acids are helpful as a part of nutritional modulation. Okay, next slide. So what is this omega-3 fatty acid in cancer? It inhibits proteolysis inducing factor and lipid mobilizing factor. This is important. We need to preserve protein and preserve lipid. It preserves or increases lean body mass. It decreases fatigue and improve quality of life. It decreases inflammatory cytokine production. It inhibits carcinogenesis and cancer growth. And it increases efficacy of chemoradiotherapy. It also reduces adverse effects of chemoradiotherapy. And that is so it has a multiple level activity, right from preventing the catabolism to increase the anabolism of the body. It also improves the quality of life of patients, reduces the inflammatory nature of the body, and it improves the tolerance to effective cancer treatment is like chemoradiotherapy. Okay, next slide. So another one is, what is this eicosapentaenoic oncology-specific acid. What is its effect on body composition and markers of inflammation with head and neck cancer? It modulates pro-inflammatory cytokine synthesis. So I just showed you in the first slide that these are the culprit cytokines that cause catabolism. So it reduces these levels. It improves the inflammatory state, especially interleukin 10, and it maintains muscle and fat mass, and it improves the quality of life of these patients. Okay. So these are some effects of EPA. Okay. Next slide. So this is another paper where it showed that enteral nutrition with eicosapentaenoic acid and DHA may be advantageous in patients with head neck cancer or esophageal cancer by improving parameters of nutrition and functional status during chemotherapy. So these pentaenoic acid and DHA are helpful in reducing the inflammatory nature of cancer and also reduces toxicity to chemotherapy and improves tolerance. Hence, these are some papers which have shown some positive results. We always speak of benefit by 0.5% if I add cisplatin to radiotherapy. If I use intensity modulated radiotherapy, I improve the outcome. So nobody speaks of nutrition. If I do nutrition supplementation, the quality of life of the patient improves. So this is less well recognized than the anti-cancer therapy part. Okay, next slide. Yes. So this is another paper of EPA on nutritional and clinical outcomes in lung cancer patients. Okay, non-small cell lung cancer. Okay, next slide. Keep moving. Keep moving.
Just a moment, sir. Just a moment.
Okay, I think we have come to the end of the session. I think so. In lung cancer patients, also, if you can give EPA and DHA, it is beneficial, and the cancer-related outcomes are better. I think we have come to the end of presentation, saying that nutrition is a neglected part of cancer care, and we must consider nutrition to be an intrinsic component of care. So I think we have come to the final statement that EPA and DHA have some evidence because they bypass circulation, they reduce the inflammatory component, and so on. So with this, with final take-home messages, always do nutritional assessment in the right from the first day onwards. And if there is a nutritional insufficiency, for example, whether the patient is in pre-critic state or what, once you assess, you try to find out the reason for it. And moment you have the reason for it, and if you feel appetite is an issue or intake is less, then you can have oral nutritional supplements. And if you look into a patient who is undergoing chemotherapy, radiotherapy, in those patients, glutamine, EPA, and DHA have shown beneficial. And we must always remember what is the calorie, protein, lipid requirement of a patient with cancer. So with all these remarks, I will just come to a conclusion, and I would thank Fresenius to provide me an opportunity to speak and share my knowledge with others, and thanks everyone for their patient listening. Yeah.